Question 1. A patient has an ECG strip showing irregular RR intervals, no discernible P waves, and a rapid ventricular rate of 150 BPM. Which arrhythmia is most likely? A. Atrial fibrillation. B. Atrial flutter. C. Ventricular tachycardia. D. Sinus tachycardia. Answer: A. Atrial fibrillation. Rationale: atrial fibrillation presents with irregularly irregular RR intervals, absent P waves, and a rapid ventricular response. Atrial flutter typically has a sawtooth pattern of P waves. Ventricular tachycardia has wide QRS complexes, and sinus tachycardia has a regular rhythm. Question 2. What is the primary concern when a patient presents with ventricular fibrillation? A. High risk of clot formation. B. Ineffective myocardial contraction and absence of pulse. C. Risk of hypoxia due to rapid respiration. D. Increase in blood pressure. Answer: B. Ineffective myocardial contraction and absence of pulse. Rationale: ventricular fibrillation results in uncoordinated electrical activity, causing the heart to quiver instead of contract effectively, leading to no pulse and lack of circulation. Other options do not directly pertain to the life-threatening nature of VF. Question 3. A 65-year-old patient has an ECG showing QRS complexes that are wider than 0.12 seconds and a rate of 40 BPM. What is the most likely rhythm? A. Sinus bradycardia. B. Third-degree heart block. C. Idioventricular rhythm. D. Junctional escape rhythm. Answer: C. Idioventricular rhythm. Rationale: idioventricular rhythm is characterized by a slow heart rate, typically 30 to 40 BPM, with wide QRS complexes, indicating that the ventricles are generating the rhythm. Third-degree heart block also has a slow rate, but would have more pronounced PQRS dissociation. Question 4. A 45-year-old male with a history of hypertension presents with an ECG showing a regular rhythm of 85 BPM with tall, peak T waves. What could be the underlying cause? A. Hyperkalemia. B. Hypokalemia. C. Atrial fibrillation. D. Acute myocardial infarction. Answer: A. Hyperkalemia. Rationale: tall, peak T waves on an ECG are characteristic of hyperkalemia, which can lead to cardiac arrhythmias. Hypokalemia typically presents with flattened T waves and U waves. Question 5. Which of the following arrhythmias is most likely to require immediate defibrillation? A. Atrial fibrillation. B. Torsade de pointes. C. Atrial flutter. D. Sinus bradycardia. Answer: B. Torsades de pointes. Rationale: torsades de pointes, a form of polymorphic ventricular tachycardia, can lead to life-threatening arrhythmias and is often treated with defibrillation. The other rhythms do not typically require immediate defibrillation. Question 6. The nurse observes an ECG with absent P waves, a narrow QRS complex, and a rate of 120 BPM. Which arrhythmia is most likely? A. Sinus tachycardia. B. Paroxysmal supraventricular tachycardia, PSVT. C. Atrial fibrillation. D. Junctional tachycardia. Answer: B. Paroxysmal supraventricular tachycardia, PSVT. Rationale: PSVT is characterized by rapid onset and termination, narrow QRS complexes, and no visible P waves, with a rate typically around 150 to 250 BPM. Question 7. What is the characteristic ECG finding for a patient with first-degree heart block? A. Prolonged PR interval. B. Absent P waves. C. Wide QRS complexes. D. Irregular RR intervals. Answer: A. Prolonged PR interval. Rationale: first-degree heart block is characterized by a prolonged PR interval greater than 0.20 seconds, with normal P waves and QRS complexes. Question 8. A patient is in ventricular tachycardia with a pulse. What is the first intervention? A. Administer atropine. B. Perform synchronized cardioversion. C. Start CPR immediately. D. Administer IV epinephrine. Answer: B. Perform synchronized cardioversion. Rationale: for ventricular tachycardia with a pulse, synchronized cardioversion is the appropriate first intervention to restore normal rhythm. Other options are used for different clinical scenarios. Question 9. A patient with acute myocardial infarction presents with ST segment elevation. What arrhythmia is most commonly associated with this condition? A. Ventricular fibrillation. B. Atrial fibrillation. C. Sinus bradycardia. D. Torsade de pointes. Answer: A. Ventricular fibrillation. Rationale: ST segment elevation indicates acute myocardial injury, which is often associated with ventricular fibrillation, a life-threatening arrhythmia that requires immediate intervention. Question 10. What ECG finding is characteristic of a patient with atrial flutter? A. Sawtooth-shaped P waves. B. Irregular rhythm. C. Wide QRS complexes. D. Absent P waves. Answer: A. Sawtooth-shaped P waves. Rationale: atrial flutter presents with a sawtooth pattern of P waves, flutter waves, due to rapid atrial depolarization, often at rates of 250 to 350 BPM. Question 11. A 70-year-old patient with a history of hypertension and diabetes presents with a slow heart rate of 40 BPM and an irregular rhythm. What is the likely diagnosis? A. Second-degree heart block type 2. B. Atrial fibrillation. C. Sinus bradycardia with premature ventricular contractions, PVCs. D. Third-degree heart block. Answer: D. Third-degree heart block. Rationale: third-degree heart block, complete block, results in a slow, irregular rate with no correlation between P waves and QRS complexes. Question 12. A patient is in rapid atrial fibrillation with a ventricular rate of 160 BPM. What is the most appropriate intervention? A. Administer adenosine. B. Perform synchronized cardioversion. C. Administer amiodarone. D. Start IV fluids. Answer: B. Perform synchronized cardioversion. Rationale: synchronized cardioversion is appropriate for patients with rapid atrial fibrillation who are symptomatic or hemodynamically unstable. Question 13. What is the most concerning aspect of an ECG showing sinus bradycardia at 40 BPM in a symptomatic patient? A. The potential for asystole. B. The likelihood of a ventricular arrhythmia. C. Inadequate cerebral perfusion. D. Risk of atrial fibrillation. Answer: C. Inadequate cerebral perfusion. Rationale: sinus bradycardia with a rate of 40 BPM can result in inadequate perfusion to the brain, leading to dizziness, syncope, or other symptoms. Question 14. Which of the following is true about the J point in an ECG? A. It represents the beginning of the QRS complex. B. It marks the end of a T wave. C. It is where the QRS complex joins the ST segment. D. It is an abnormal finding in atrial fibrillation. Answer: C. It is where the QRS complex joins the ST segment. Rationale: the J point marks the junction between the QRS complex and the ST segment, and it is important for identifying ST elevation or depression. Question 15. What ECG feature indicates that a patient is in a normal sinus rhythm? A. Regular rhythm, P waves before every QRS complex, heart rate 60 to 100 BPM. B. Irregular rhythm, absent P waves, heart rate 80 to 120 BPM. C. Sawtooth P waves, rate of 100 to 150 BPM. D. Wide QRS complexes, rate of 40 BPM. Answer: A. Regular rhythm, P waves before every QRS complex, heart rate 60 to 100 BPM. Rationale: normal sinus rhythm is characterized by a regular rhythm, P waves before each QRS complex, and a heart rate of 60 to 100 BPM. Question 16. Which of the following is a risk factor for developing atrial fibrillation? A. Hypertension. B. Hyperkalemia. C. Hypocalcemia. D. Hyperglycemia. Answer: A. Hypertension. Rationale: hypertension is a major risk factor for atrial fibrillation due to its effects on atrial remodeling and increased atrial pressure. Question 17. What intervention is indicated for a patient with a third-degree heart block and no symptoms? A. Immediate defibrillation. B. Pacemaker insertion. C. Vagal maneuvers. D. Medication adjustment. Answer: B. Pacemaker insertion. Rationale: a third-degree heart block often requires a permanent pacemaker to ensure that the heart rate remains adequate and that atrial and ventricular activities are coordinated. Question 18. A patient is experiencing a rapid rate of 150 BPM with a regular rhythm and no visible P waves. What is the most likely rhythm? A. Atrial fibrillation. B. Paroxysmal supraventricular tachycardia, PSVT. C. Sinus tachycardia. D. Ventricular tachycardia. Answer: B. Paroxysmal supraventricular tachycardia, PSVT. Rationale: PSVT presents with a regular, rapid rate, 150 to 250 BPM, and no visible P waves, often beginning and ending suddenly. Question 19. What is the primary mechanism of action for antiarrhythmic medications like amiodarone? A. Inhibition of sympathetic stimulation. B. Blocking potassium channels and prolonging repolarization. C. Increasing myocardial oxygen demand. D. Blocking calcium channels and reducing contractility. Answer: B. Blocking potassium channels and prolonging repolarization. Rationale: amiodarone works by blocking potassium channels, prolonging repolarization, and stabilizing the rhythm. Question 20. A patient presents with an irregular rhythm, a rapid ventricular rate of 180 BPM, and no visible P waves. What is the next best intervention? A. Perform synchronized cardioversion. B. Start an antiarrhythmic infusion. C. Administer a beta blocker. D. Administer digoxin. Answer: A. Perform synchronized cardioversion. Rationale: for patients with atrial fibrillation and a rapid ventricular rate who are symptomatic, synchronized cardioversion is the preferred intervention. Question 21. A 50-year-old patient presents with a prolonged QT interval of 0.52 seconds, polymorphic ventricular tachycardia, and a history of syncope. What is the most likely diagnosis? A. Torsade de pointes. B. Atrial flutter. C. Hypokalemia. D. Second-degree heart block type 2. Answer: A. Torsade de pointes. Rationale: torsades de pointes is characterized by a prolonged QT interval, often due to electrolyte disturbances or medications, leading to polymorphic ventricular tachycardia. Question 22. A patient with a history of heart failure presents with a ventricular rate of 40 BPM, absent P waves, and wide QRS complexes. Which arrhythmia should be suspected? A. Idioventricular rhythm. B. Atrial fibrillation with a slow ventricular response. C. First-degree heart block. D. Third-degree heart block. Answer: A. Idioventricular rhythm. Rationale: idioventricular rhythm is characterized by a slow rate, often 30 to 40 BPM, wide QRS complexes, and no P waves, often seen in patients with severe heart failure. Question 23. In a patient with suspected acute pericarditis, what ECG finding is most characteristic? A. Diffuse ST segment elevation in most leads. B. Absent P waves with a wide QRS complex. C. Q waves in V1 and V2 to D. T-wave inversion in leads 1, 2, and AVL. Answer: A diffuse ST segment elevation in most leads. Rationale: acute pericarditis is associated with diffuse ST segment elevation in most leads, often without reciprocal ST depression. Question 24. A patient with a history of myocardial infarction presents with a regular rhythm, a rate of 60 BPM, and a deep, wide S wave in lead V1 with an R wave greater than 25 mm in lead V5. What is the most likely rhythm? A. Left bundle branch block LBBB. B. Right bundle branch block RBBB. C. Ventricular tachycardia. D. Atrial fibrillation. Answer: A. Left bundle branch block LBBB. Rationale: LBBB is characterized by a wide QRS complex, greater than 0.12 seconds, deep S wave in V1, and a large R wave in V5, commonly seen in patients with coronary artery disease. Question 25. A 70-year-old patient presents with a prolonged PR interval of 0.32 seconds, a dropped QRS complex, and a regular P wave pattern. What is the most likely diagnosis? A. First-degree heart block. B. Second-degree heart block type 2. C. Third-degree heart block. D. Second-degree heart block type I Wenckebach. Answer: B. Second-degree heart block type 2. Rationale: second-degree heart block type 2 presents with a prolonged PR interval, occasionally dropping QRS complexes, with a regular pattern of P waves. Question 26. A 60-year-old patient presents with an irregular rhythm, narrow QRS complexes, and a ventricular rate of 150 BPM with visible P waves. What is the most likely diagnosis? A. Atrial fibrillation. B. Atrial flutter. C. Paroxysmal supraventricular tachycardia, PSVT. D. Junctional tachycardia. Answer: C. Paroxysmal supraventricular tachycardia, PSVT. Rationale: PSVT is characterized by a rapid, regular rhythm with a ventricular rate around 150 to 250 BPM, narrow QRS complexes, and visible P waves. Question 27. A 65-year-old patient presents with an ECG showing a wide QRS complex, a rate of 30 BPM, and no discernible P waves. What is the most appropriate initial treatment? A. Defibrillation. B. Synchronized cardioversion. C. Atropine administration. D. Pacemaker insertion. Answer: D. Pacemaker insertion. Rationale: the patient's presentation suggests a complete block of electrical conduction in the AV node or bundle, requiring a pacemaker for proper conduction and rate support. Question 28. A patient presents with ST segment depression in leads 1, 2, and V3, V6, accompanied by T-wave inversion in the same leads. What is the most likely diagnosis? A. Acute myocardial infarction. B. Acute pericarditis. C. Unstable angina. D. Coronary artery spasm. Answer: C. Unstable angina. Rationale: ST segment depression and T-wave inversion are classic findings in unstable angina, indicating myocardial ischemia without infarction. Question 29. A 55-year-old patient presents with syncope, an ECG showing a prolonged PR interval, and a dropped QRS complex every third P wave. What is the most likely rhythm? A. First-degree heart block. B. Second-degree heart block type I Wenckebach. C. Second-degree heart block type 2. D. Third-degree heart block. Answer: B. Second-degree heart block type I Wenckebach. Rationale: Wenckebach is characterized by a progressively prolonged PR interval followed by a dropped QRS complex, commonly occurring every third or fourth P wave. Question 30. A patient with a history of hypertension and diabetes presents with an ECG showing a rapid, irregular rhythm with no visible P waves, a ventricular rate of 130 BPM, and a widened QRS complex. What is the most likely diagnosis? A. Atrial fibrillation. B. Atrial flutter with variable block. C. Ventricular tachycardia. D. Multifocal atrial tachycardia. Answer: A. Atrial fibrillation. Rationale: atrial fibrillation presents with an irregularly irregular rhythm, absent P waves, and a rapid ventricular response. Question 31. A patient with suspected hyperkalemia has an ECG showing peak T waves, a prolonged PR interval, and a widened QRS complex. What is the most appropriate intervention? A. Administer sodium bicarbonate. B. Perform synchronized cardioversion. C. Administer calcium gluconate. D. Start adenosine infusion. Answer: C. Administer calcium gluconate. Rationale: calcium gluconate is used to stabilize the myocardium in hyperkalemia, preventing arrhythmias associated with elevated potassium levels. Question 32. A patient with a history of mitral valve prolapse presents with an ECG showing a prolonged QT interval, syncope, and polymorphic ventricular tachycardia. What is the most likely diagnosis? A. Long QT syndrome. B. Atrial fibrillation. C. Sinus tachycardia. D. Torsades de pointes. Answer: A. Long QT syndrome. Rationale: long QT syndrome predisposes patients to polymorphic ventricular tachycardia, such as torsades de pointes, particularly in the setting of syncope and a prolonged QT interval. Question 33. A patient with a history of cocaine use presents with a wide complex tachycardia at a rate of 150 BPM and absent P waves. What is the most likely diagnosis? A. Atrial fibrillation. B. Wolff-Parkinson-White syndrome. C. Ventricular tachycardia. D. Paroxysmal supraventricular tachycardia, PSVD. Answer: C. Ventricular tachycardia. Rationale: cocaine use can lead to ventricular tachycardia, characterized by a wide QRS complex, a rate of greater than 120 BPM, and absent P waves. Question 34. What is the primary pathophysiologic mechanism behind atrial fibrillation? A. Reentry circuit in the atria. B. Impaired conduction through the AV node. C. Excessive sympathetic stimulation. D. Blockage of coronary arteries. Answer: A. Reentry circuit in the atria. Rationale: atrial fibrillation is caused by multiple rapid reentry circuits in the atria, leading to disorganized electrical activity and an irregularly irregular rhythm. Question 35. A 65-year-old patient presents with an ECG showing a wide, bizarre QRS complex and a compensatory pause after the complex. What is the most likely rhythm? A. Premature ventricular contraction, PVC. B. Ventricular tachycardia. C. Atrial premature complex, APC. D. Junctional escape rhythm. Answer: A. Premature ventricular contraction, PVC. Rationale: PVCs are characterized by wide, bizarre QRS complexes, followed by compensatory pause, and are often seen in patients with heart disease or electrolyte imbalances. Question 36. A patient with suspected pulmonary embolism presents with sinus tachycardia, an increased RV1 and V1R wave, and an S wave in lead V6. What is the most likely ECG finding? A. Right ventricular strain pattern. B. Left bundle branch block, LBBB. C. Atrial fibrillation. D. Torsades de pointes. Answer: A. Right ventricular strain pattern. Rationale: a right ventricular strain pattern, seen in conditions like pulmonary embolism, is characterized by an increased R wave in V1 and an S wave in V6. Question 37. A patient in the emergency room presents with an ECG showing a rate of 200 BPM, narrow QRS complexes, and no visible P waves. What is the best initial treatment? A. Defibrillation. B. Synchronized cardioversion. C. Vagal maneuvers. D. Adenosine administration. Answer: D. Adenosine administration. Rationale: the patient is likely in PSVT, which is initially treated with adenosine to slow the conduction and restore normal rhythm. Question 38. A patient with hyperthyroidism presents with a rapid heart rate of 160 BPM, wide QRS complexes, and no visible P waves. What is the most likely diagnosis? A. Ventricular fibrillation. B. Atrial fibrillation with rapid ventricular response. C. Paroxysmal supraventricular tachycardia, PSVT. D. Sinus tachycardia. Answer: B. Atrial fibrillation with rapid ventricular response. Rationale: hyperthyroidism can predispose to atrial fibrillation, which presents with a rapid ventricular rate, no P waves, and irregular RR intervals. Question 39. A patient with a history of stroke presents with an ECG showing normal sinus rhythm, but the QT interval is 0.52 seconds. What is the most concerning risk in this patient? A. Risk of ventricular arrhythmias. B. Risk of deep vein thrombosis, DVT. C. Risk of myocardial infarction. D. Risk of coronary artery spasm. Answer: A. Risk of ventricular arrhythmias. Rationale: a prolonged QT interval is a risk factor for life-threatening arrhythmias, particularly torsades de pointes, which can lead to sudden cardiac arrest. Question 40. A 60-year-old patient presents with a history of myocardial infarction and is found to have ST segment elevation in leads V1 to V4. What is the most likely diagnosis? A. Anterior wall myocardial infarction. B. Inferior wall myocardial infarction. C. Lateral wall myocardial infarction. D. Posterior wall myocardial infarction. Answer: A. Anterior wall myocardial infarction. Rationale: ST segment elevation in leads V1 to V4 is characteristic of an anterior wall myocardial infarction, often involving the left anterior descending artery. If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying!